surgical repair of combined tractional and rhegmatogenous retinal detachment. 37-year-old type 1 diabetic with proliferative diabetic retinopathy presents with tractional fibrosis emanating from the nerve towards the supratemporal and nasal periphery. A retinal hole is noted in the nasal mid-periphery, contributing to the rhegmatogenous component of the retinal detachment. The retina is bullously detached nasally superiorly with fluid extending into the macula. The vision in the left eye is light perception due to complicated prior tractional retinal detachment surgery prior to the patient's presentation to our clinic. Surgery is begun with a core vitrectomy. A peripheral PVD is already noted. The peripheral PVD is extended 360 degrees. The anterior and posterior vitreous are then separated. The peripheral vitreous is trimmed. The posterior vitreous is also trimmed surrounding the posterior fibrosis. At this time, bimanual technique is used. Bimanual technique is especially useful in combined tractional and rhegmatogenous retinal detachment, as it provides a second hand to safely remove any dense fibrosis from bullously detached retina. Here, forceps and horizontal scissors are used to lift up the fibrosis and delaminate the tractional membranes from the detached retina. It is important to be in the correct plane while delaminating and segmenting. The vitreous cutter is used at times to trim any delaminated membranes to improve visualization of further dissection. Once the tractional fibrosis is completely removed here, air fluid exchange is used to drain the subretinal fluid through the prior retinal break. In this way, the retina is completely reattached. Endolaser is then used to barricade the retinal hole. PRP is then filled in as needed. SF6 gas was used as gas tamponade. Top month 1, the patient's vision had surprisingly improved to 20/30, likely due to good macular perfusion and ellipsoid zone preservation.